Good afternoon, and welcome. Today, we delve into a deeply complex and often debated question within medical ethics. Is it ethical to use placebo treatments in mental health research? This issue sits at the challenging intersection of scientific necessity and our profound duty to protect vulnerable individuals seeking help. It's a topic that evokes strong opinions, and rightly so, given the potential impact on patient well-being and the future of psychiatric care. Joining us to explore this are Dr. Samuel Green, a clinical researcher who will argue for the continued use of placebo controls, and Ms. Hannah Reza, a patient advocate and ethicist who will present arguments against their use. We anticipate a thoughtful and respectful discussion. Dr. Green, would you please begin with your opening statement?
Thank you, Dr. Vance. Good afternoon. The use of placebo-controlled trials in mental health research is, in my view, not only ethical, but scientifically indispensable for the advancement of effective psychiatric care. These trials represent the gold standard, the most rigorous method we have to determine whether a new treatment genuinely works, or if perceived improvements are due to other factors. The scientific rationale is clear. We must differentiate the true pharmacological effects of a medication from the placebo effect, the natural fluctuations of an illness, or even observer bias. Without this distinction, we risk embracing treatments that offer no real benefit beyond suggestion or hope. Consider the history of medicine. It's littered with interventions once believed effective, later proven inert, or even harmful when subjected to rigorous placebo-controlled study. Mental health is no exception, and the stakes are incredibly high. We need robust, irrefutable evidence to ensure that new treatments are not only effective, but also safe. Adopting therapies based on less stringent evidence could expose countless patients to ineffective interventions, potential side effects without therapeutic gain, and delay access to treatments that truly work. I am, of course, acutely aware of the ethical concerns surrounding placebo use, particularly the idea of withholding active treatment. However, these trials are conducted under strict ethical oversight. Institutional review boards, or IRBs, meticulously scrutinize research protocols. Informed consent processes are designed to be comprehensive, ensuring participants understand they might receive a placebo and the potential implications. Furthermore, safeguards, such as clear criteria for withdrawal, regular monitoring for deterioration, and the availability of rescue medication, are standard components of ethical trial design. The duration of placebo exposure is also kept to the minimum necessary to achieve valid scientific results. Ultimately, the ethical justification rests on a carefully weighed balance. The potential controlled risk to a relatively small group of research participants is accepted to gain knowledge that can benefit a much larger population of future patients. This utilitarian perspective, while not without its critics, is fundamental to medical progress. Without placebo-controlled trials, our ability to develop and validate new, genuinely effective treatments for debilitating mental health conditions would be severely compromised. And that, I believe, would be a greater disservice to those we aim to help.
Thank you, Dr. Vance. Dr. Green, while I appreciate the scientific arguments you've presented, I must fundamentally challenge the ethical permissibility of using placebos in much of mental health research, particularly when effective treatments are already known to exist. My primary concern centers on the profound vulnerability of individuals grappling with mental health conditions. These are often people in distress, sometimes desperate for relief, and their capacity to navigate the complexities of informed consent for a trial involving a potential placebo can be significantly compromised. The very nature of conditions like severe depression, psychosis, or anxiety can impair cognitive functions, judgment, and the ability to fully grasp the implications of randomization to a non-active substance. Can we truly say consent is fully informed under such circumstances, even with the best intentions of researchers? This leads to the pervasive issue of therapeutic misconception. Many participants, despite explanations, enroll in clinical trials with the underlying belief or hope that they are receiving a cutting-edge treatment, not an inert pill or procedure. The potential for disappointment, a sense of betrayal, and a worsening of their condition, if they are on placebo and their illness progresses untreated, is immense. To knowingly withhold an established, effective treatment from someone in need, even for the duration of a research study, raises serious ethical red flags. The principle of primum non nocere, first, do no harm, seems directly challenged here. Are we, in the pursuit of scientific purity, risking tangible harm to individuals who have placed their trust in the medical research system? The argument that these risks are mitigated by ethical oversight and informed consent, while important, doesn't fully address the power imbalance inherent in the researcher-participant relationship, especially when dealing with individuals whose autonomy may be diminished by their illness. Furthermore, for many mental health conditions, effective treatments do exist. In such cases, the ethical bar for justifying a placebo control group, rather than comparing a new agent against an existing standard of care, should be extraordinarily high, if not insurmountable. The potential benefit to future populations must be weighed against the concrete risk of suffering and deterioration in current research participants. I believe we often underestimate this individual burden in our quest for generalizable knowledge. Therefore, I contend that the routine use of placebos in mental health research needs urgent reevaluation, prioritizing patient well-being, and exploring alternative research designs that do not necessitate the denial of potentially effective care.
Ms. Reza, you raise valid and deeply felt concerns about patient vulnerability and the integrity of informed consent. These are matters that researchers and ethics committees take extremely seriously, and I don't wish to downplay them. However, the safeguards we have are not mere formalities. The informed consent process is often iterative, involving detailed discussions, written materials in clear language, and opportunities for potential participants to ask questions and consult with family or trusted advisors. Capacity to consent is also a key assessment point. Moreover, ethics committees are independent bodies, specifically tasked with protecting research subjects. They scrutinize participant selection, the clarity of information provided, and the measures in place to minimize risk and manage any adverse events, including psychological distress. You mentioned the risk of withholding effective treatment. It's crucial to remember that many placebo-controlled trials are conducted precisely because existing treatments are not universally effective, or their efficacy in specific populations is unknown. For many patients entering trials, standard treatments may have already failed them. And consider the alternative. If we shy away from placebo controls, we risk approving treatments that are no better than placebo, but carry side effects. Is it ethical to expose patients to such interventions, potentially for years, under the false pretense of efficacy? That would also be a failure of our duty of care. On a much larger scale, the goal is not to deny care, but to ensure that the care we provide in the future is genuinely beneficial. Without a placebo benchmark, especially in conditions with high placebo response rates like depression or anxiety, we are navigating in the dark.
Dr. Green, while I acknowledge the intention behind these safeguards, I remain concerned about their consistent and effective application in the real world, particularly when dealing with individuals experiencing acute psychiatric distress or those who feel they have no other options. The power dynamic between a researcher, often seen as an authority figure offering potential hope, and a vulnerable patient, cannot be overstated. Even with the best communication, the subtle pressures and the patient's own desperation can undermine true voluntariness. Your argument about the greater good is a common justification, but it becomes ethically perilous when it involves the potential for significant, foreseeable harm to identifiable individuals. We must ask if the ends always justify these particular means, especially when the harm includes deterioration of a serious mental illness. Furthermore, I believe there is an insufficient emphasis on and funding for alternative research designs that could mitigate these ethical dilemmas. Comparative effectiveness trials, which compare new treatments directly against current standard of care active treatments, offer a more ethically sound approach when effective treatments already exist. Add-on designs, where a new treatment is added to an existing regimen rather than replacing it with a placebo, could also be more widely employed. While these designs may have their own methodological complexities, they prioritize the participants' access to established care. Relying so heavily on placebo-controlled trials, especially in areas where we aren't starting from zero, suggests a lack of will or creativity in adopting these more patient-protective methodologies.
Thank you both for those insightful rebuttals, Dr. Green. Ms. Reza mentioned alternative research designs, like comparative effectiveness trials. In what specific situations, if any, do you believe these could adequately replace placebo-controlled trials in mental health research? Or what are their limitations in your view?
That's an important question. Comparative effectiveness trials are valuable, particularly for head-to-head comparisons, once a drug's basic efficacy is established. However, to establish that initial efficacy, especially for a novel compound or a new indication, a placebo arm is often essential to demonstrate that the drug does more than just match an existing treatment, or more than nothing at all. Without knowing if a drug is superior to placebo, a non-inferiority finding against an active comparator might simply mean both are equally ineffective, or equally effective only due to placebo effects. This is a critical nuance.
And, Dr. Green, how do you respond to the persistent concern that the very nature of some mental illnesses might impair a person's ability to give truly informed consent to a trial where they might receive a placebo, despite the protocols you've outlined?
It's a valid concern that requires ongoing vigilance. Assessment of decisional capacity is key. If capacity is significantly impaired, a legally authorized representative would be involved. Furthermore, the information must be presented in multiple formats and understanding checked. It's not a perfect system, but it's a structured attempt to respect autonomy while enabling vital research.
Ms. Reza, turning to you. If we were to significantly reduce or abandon placebo trials in mental health, as you advocate, how can we confidently ensure that new treatments are genuinely effective and not just a result of the placebo effect? Especially in a field where subjective improvement plays such a large and often variable role?
That is the crux of the challenge, Dr. Vance. I'm not advocating for no rigor, but for different rigor. It means investing more in understanding the placebo effect itself and designing trials that can account for it without resorting to deceptive placebos where active treatments are an option. This could involve more sophisticated statistical methods, observational studies with robust methodologies, and, as mentioned, a greater reliance on active comparator trials, especially when an accepted standard of care exists. It's about shifting the ethical balance.
And, Ms. Reza, are there any circumstances, perhaps in conditions with no known effective treatments, or in very early phase research, where you would consider a placebo-controlled trial ethically justifiable in mental health research?
Perhaps, but with extreme caution and stringent criteria. If there are genuinely no established treatments, and the condition is serious, and the potential benefits are substantial, and the risks of placebo exposure are minimal and brief, and consent is impeccably obtained from individuals with full capacity, then it might be considered. But this should be the absolute exception, not the rule. In closing, I want to re-emphasize the core ethical objections to the widespread use of placebos in mental health research. We are dealing with an exceptionally vulnerable population, and the potential for exploitation, however unintentional, is ever present. The act of withholding available, effective treatment, or providing an inert substance to someone in profound psychological distress carries a significant risk of harm, not just a lack of benefit, but actual deterioration or prolonged suffering. This, I believe, often violates the fundamental medical principle to do no harm. The challenges to achieving truly informed consent, free from therapeutic misconception or the subtle coercion of desperation, are immense in this context. Even with the best protocols, the inherent power imbalance and the nature of mental illness can compromise a patient's autonomy. We must therefore champion a more patient-centered approach to research ethics. This means prioritizing the immediate well-being of research participants and actively seeking, funding, and validating alternative research methodologies that do not necessitate deception or the denial of care. Comparative effectiveness studies, innovative statistical approaches, and add-on trial designs should become more standard, not just niche alternatives. It's time to shift the paradigm towards research that is not only scientifically sound, but also unequivocally ethical and compassionate to the individuals who make that research possible.
Thank you. In my concluding remarks, I must reiterate the scientific and indeed ethical imperative for placebo-controlled trials in mental health research. While the concerns raised by Ms. Riza are valid and must always inform our practice, abandoning this methodology would represent a significant step backward for psychiatric medicine. Placebos are not used lightly. They are a critical tool to ensure that new treatments are genuinely effective and safe before they are introduced to the wider patient population. Without them, we cannot reliably distinguish true therapeutic effects from the powerful influence of expectation, natural recovery, or other confounding factors so prevalent in mental health. The ethical frameworks we operate within, rigorous IRB review, comprehensive informed consent, minimization of risk, and clear withdrawal criteria, are specifically designed to protect research participants. These are not token gestures. They are robust safeguards that are constantly being refined. The long-term ethical imperative is to provide patients with treatments that actually work. Approving ineffective or minimally effective drugs, or drugs whose risks outweigh their poorly understood benefits, would be a far greater ethical failing, affecting millions. Placebo trials are our best defense against this. Ethical vigilance is, of course, paramount. We must continually strive to improve our methods and minimize any burden on participants. However, to abandon placebo-controlled trials entirely would be to impede crucial progress in alleviating the suffering caused by mental illness, and that is a consequence we cannot afford.
Dr. Green, Ms. Reza, thank you both for an exceptionally insightful and commendably respectful debate on this challenging topic. You've articulated your positions with clarity and conviction. We've heard strong arguments for the scientific necessity of placebo controls in ensuring treatment efficacy from Dr. Green, countered by Ms. Reza's profound concerns for patient vulnerability, and the ethical imperative to avoid withholding care. It's clear that this issue involves a delicate and complex balancing act. The drive for scientific rigor and medical advancement on one hand, and our fundamental ethical duties to protect and care for vulnerable individuals on the other. The questions raised today do not have easy answers, and the discussion around the ethical conduct of mental health research will, and indeed must, continue. Thank you both again, and thank you to our audience.